What if a single piece of legislation could basically flip the script on healthcare, reverse, a decade of coverage gains, and really reshape the entire industry for years? Well, that's exactly what we're diving into today. We're looking at President Trump's One Big Beautiful Bill Act, the OBBA, which was signed into law on July 4th, 2025. It's this truly massive budget bill, sweeping changes across U.S. healthcare. Our analysis today comes from a pretty comprehensive look at its impact on the big insurers, the BUKAs like United Healthcare, the Blues, Kaiser, Aetna, and also on Medicaid and the ACA markets. And our mission for you, our listener, whether you're a health executive, founder, analyst thinking about policy, is to pull out the most critical insights. We'll break down
That's
strategic
true.
fallout, yeah. Focusing on what smart health plan companies should be doing now, but maybe aren't. The
Mhm.
goal is really to give you that foresight, help you see where the market's headed so you can act before the ground shifts. And just to start, here's something pretty staggering. The CBO, the Congressional Budget Office, they project these changes could leave roughly 17 million more Americans uninsured. That's true. Well, it's projected to be the biggest coverage drop ever from federal policy.
Yeah.
So, okay, let's unpack this.
It's definitely a seismic shift. You're right. The OBBBA, it really goes after Medicaid structure. We're
Mm.
talking over $1 trillion in federal spending cuts, mostly from Medicaid. It's actually the largest set of cuts in the program's history.
$1 trillion.
Yeah.
Wow, that figure alone is just massive. How does the bill actually make those cuts happen?
Well, a big one is work requirements. For the first time federally, able-bodied adults, age 19 to 64, they have to work 80-plus hours a month or, qualify for some limited exemptions to keep their Medicaid. States have to get this running by 2027, maybe 2028.
Okay, 80 hours a month.
Yeah. And what's really crucial to grasp here, based on past state tries, is that a lot of the coverage loss isn't just people not working. It's often the paperwork, the reporting rules, the red tape. It's complex, and even people with jobs struggle to keep up. So the process itself becomes a barrier.
That's a really important point for practical impact. And it's not just work rules, is it? There are changes to immigrant eligibility, too.
That's right. Big changes there. Starting October 1st, 2026, certain groups of legal immigrants, refugees, asylees, humanitarian parolees, they won't be eligible for Medicaid or Medicare anymore. It really shrinks the safety net for some very vulnerable people. Basically, eligibility gets limited mostly to citizens, long-term permanent residents after 5 years, and a few other specific groups.
Okay. So beyond who's eligible, how does this bill tighten the screws on the states, on their funding for Medicaid?
Yeah, hit states hard, federal matching funds. They're now capped and curtailed, less money from D.C.
What?
Plus, it freezes and then phases down provider taxes, the tool states use to help fund their share. It goes from 6% down to 3.5% by 2031.
Oh, okay.
And it limits how much states can boost hospital payments, too, capping certain payments at Medicare rates. And then there's the churn factor. States now have to check Medicaid expansion eligibility every 6 months, not annually.
6 months. Wow.
Yeah. And retroactive coverage gets shortened. All these little administrative tweaks, they're designed to increase turnover, basically, more coverage gaps.
So you add all that up. What's the CBO's projection for Medicaid enrollment? And what does this mean for states already feeling stretched?
The bottom line from CBO is at least 10 to 11 million fewer people enrolled in Medicaid and CHIP by 2034. Just from these changes. So states face these really brutal choices, either find a lot more money in their own general funds, which is politically tough, or cut back, cut enrollment, cut benefits.
And optional benefits like home care
Yeah,
often go first.
exactly.
Yeah.
That's what research suggests. Optional benefits are often the first on the chopping block. And think bigger picture. Cuts this deep, they ripple out, they strain hospitals, could lead to closures, even healthcare job losses, especially in poorer areas.
Right. And it's not just Medicaid taking a hit. The OBBBA is also reshaping the ACA marketplaces pretty significantly. What are the key changes there?
Well, the absolute monster change is letting those pandemic-era enhanced premium tax credits expire after 2025.
Ah, the ARPA subsidies.
Exactly. They help millions afford plans. Without them, premiums jump sharply. That expiration alone. CBO thinks it prices out about 4.2 million people. It's like a $700 average cost hike per person who loses those extra subsidies.
$700 average hike. Ouch. So cost goes way up for many. What about just getting enrolled or staying enrolled? Is that harder too?
Oh, definitely harder.
Mm.
The bill gets rid of automatic re-enrollment for subsidized plans.
No auto renewal.
Nope. Everyone getting subsidies has to actively come back every year, re-verify income, pick a plan, or they lose the help. And think about this. Over half of returning folks, like 11 million people in 2025, used auto renewal. So that's a big potential tripwire.
Yeah, that's huge.
Plus, they ended the special enrollment period for lower-income people that allowed year-round signups. And the main open enrollment window, it's shorter now, just November 1st to December 15th nationwide. Used to run longer in many states.
That's a tight window, especially when you said like 40% signed up after December 15th before.
Exactly. So that shorter window could catch a lot of people out.
Wow, lots of new hurdles. And what about income verification and those clawbacks if your income changes?
Yeah, they tightened that up too. No more provisional subsidies while your application is processing.
Yeah.
You got to pay the full premium up front until everything's verified. And they removed the caps on subsidy clawbacks. So if you underestimate your income, even by a bit, you have to repay all the excess subsidy at tax time. No limit.
Ooh.
Yeah. That adds a lot of financial risk, especially for families with unsteady incomes. It might make them hesitant to even use the subsidies.
Okay, now shifting gears slightly, there are some technical tweaks in there about health savings accounts, HSAs. How do those fit in? Are they like a counterweight or just a smaller detail?
That's a good question. The OBBBA does nudge towards consumer-driven plans. It lets high-deductible plans cover telehealth before the deductible without messing up HSA eligibility. And it makes bronze and catastrophic plans HSA qualified. Plus, it clarifies that direct primary care, DPC, isn't technically insurance.
Right, so you can use HSA money for DPC fees now.
Exactly. So yes, these are flexibilities.
Yeah.
But they mostly help people manage out-of-pocket costs, right? They don't really counteract the huge number of people potentially losing coverage altogether. It's more tweaking the market for a specific segment.
Got it. So, the Bill's Law. Industry's looking ahead. What's the immediate vibe like the next year or two? What are plans dealing with right now?
Right now, uncertainty. That's the big word through 2025. Insurers setting their 2026 rates. They're basically guessing how the subsidy cliff and these new rules will land. Some big players, like United Healthcare, apparently filed 2 different sets of rates for 26, hedging their bets, basically planning for this OBBA world where, say, cost-sharing help continues, but those enhanced ARPA subsidies are gone.
2 sets of rates. That says a lot.
It does. And actuaries, they're projecting ACA premiums could jump an extra 7 to 11% beyond normal increases by 2026 because of all this.
It's interesting, though. The anxiety seems immediate, even though the really big coverage hits, like the Medicaid work rules, are still a year or 2 away, right?
Yeah.
Late 26, 27.
Yeah, you've hit on something key there. The preparation is immediate. State Medicaid agencies, they're already scrambling, diverting money and staff to build the IT systems, the processes for work verification. They have deadlines.
Right.
And hospitals, clinics, especially rural ones, they're on high alert. Some are freezing hiring, putting expansion plans on hold. They see the writing on the wall about uncompensated care going up. They're bracing now for what's coming.
And how are insurers themselves reacting, repositioning right now?
Well, Medicaid managed care plans are definitely prepping for membership to shrink. Some insurers might pull back on ACA marketing or even exit some states' individual markets after 2025 if the numbers look bad. But conversely, many are doubling down on the stable stuff, especially Medicare Advantage.
MA, untouched by this for citizens, right? And still growing demographically.
Exactly. Baby boomers aging in. So for diversified insurers, MA is a place to lean into to offset potential losses elsewhere.
Okay, so that's the short term. Let's look a bit further out. The core shift, maybe 2026 through 2030. What does the landscape look like then as these changes really bite?
Yeah, late 26 into 27, that's when we expect the big wave of Medicaid disenrollment to hit hard because of work rules and eligibility checks. CBO thinks 7 to 8 million fewer on Medicaid within a decade from these OBBBA rules. Plus, remember, those legal immigrant groups, refugees, ACLEs, they lose eligibility in October 26. So new enrollment stops, and some current folks will lose coverage.
And that puts states in an even tougher spot financially, doesn't it? With less federal cash and fewer tools of their own.
It's a real bind. By the late 2020s, states will either have to pony up significantly more of their own money for Medicaid, which is always hard politically, or make deep cuts. Eligibility, benefits, provider payments, and forget about more states expanding Medicaids under these conditions. Some might even think about rolling back existing expansions if the fiscal pressure gets too intense. We could see Medicaid shrink back considerably in some places.
Okay, turning to the ACA marketplaces again. What's the story there by, say, 2030?
Well, 2026 is the big shock year when those enhanced subsidies vanish. Millions of middle-income folks see premiums skyrocket. Many will likely drop coverage.
That was the 3-4 million CBO estimate just from the ACA changes.
Exactly. And add in the hassle factor, no auto renewal, shorter sign-up window.
Yeah.
It all takes toll. Insurers might end up with a smaller pool of customers, likely older and sicker on average, which, could push premiums even higher. It creates a bit of a spiral.
Yeah.
The AHA, the hospital association, they're worried it could destabilize markets. By 2030, ACA exchanges could have way fewer people enrolled, maybe a third less or even more.
And the direct result of all
Uh,
this, more uninsured Americans. How do people cope? What do consumers do?
yeah, the uninsured numbers could really swell, maybe back up towards 40 million or more in the late 2020s. That's up from around 27 million recently. Many who lose Medicaid, they'll just be uninsured. Those priced out of the ACA might look for cheaper things. Short-term plans, those can last almost a year now. Health-sharing ministries, maybe direct primary care membership.
But these aren't comprehensive insurance, mostly.
Not usually, no.
Oh.
And critically, people will likely cut back on care, delay seeing a doctor, skip preventive screenings, which means worse health outcomes down the road and probably more medical debt.
Which sounds like a huge strain on hospitals and other providers.
Oh, absolutely. More uninsured patients means more uncompensated care. That hits hospital bottom lines directly.
CBO predicted this. It especially jeopardizes hospitals that serve a lot of Medicaid patients, and rural hospitals are particularly vulnerable.
Even with that temporary rural hospital fund in the bill. Even with that $50 billion fund, yeah. It runs from 2026 to 2030. But it might not be enough for long-term survival for many. We could see more hospital closures, service cuts, and providers might try to make up for it by charging privately insured patients more. That cost shift makes employer plans more expensive for everyone.
How do you see the big insurers, the BKs, navigating this? Can they adapt?
Well, their Medicaid lines will definitely shrink, losing enrollment and revenue.
Right.
But the big, diversified players, they can often balance things out. They'll push harder on employer plans, and especially, like we said, Medicare Advantage. MA is untouched for citizens here. It's growing, and it could become an even bigger profit engine for them.
So they retrench in some areas, double down in others.
Exactly. And we'll likely see more consolidation. BKAs might scoop up smaller, struggling regional plans. By 2030, they could actually be more dominant in the employer and MA space, even if the individual market shrinks.
And what about the innovators, the smaller health plans, the startups? Is this mostly a threat, or is there an opening here?
It's definitely both. If your whole model was built on, say, ACA expansion numbers, you've got to pivot fast. But for agile companies, this disruption is a huge opportunity. There will be gaps, needs unmet by the big guys. This is the moment for creative solutions. Low-cost subscription models, maybe leaner skinny plans, association health plans, things traditional insurers might be too slow or unwilling to chase aggressively.
As all this plays out, what about the politics? Could we see a backlash grow as millions lose coverage?
That's the million-dollar question, isn't it? Historically, big cuts to popular programs can create political blowback. By, say, 2028 or 2030, if the uninsured rate really jumps, you could absolutely see pressure build to restore funding or ease some rules.
States might act on their own, too?
Possibly. Some states might try their own fixes, state-level mandates or subsidies, but without that kind of action. The path for the next few years looks like a smaller government footprint in healthcare coverage.
Okay, let's zoom out even further. The long game. Say into the early 2030s. If these policies stick, what's the new normal?
Well, the CBO projection goes out to 2034, showing about 17 million fewer insured people. That basically wipes out the coverage gains from the ACA. We could see the uninsured rate nearly double from its recent low point in 2023. Health insurance might feel, once again, much more like something tied just to having a good job or having wealth, which, deepens disparities, leads to worse health outcomes overall.
And that level of uninsurance, could it change the whole debate?
It could. If the system leaves so many people behind, it might well reignite calls for more fundamental change. Maybe renewed interest in something like Medicare for All if the current approach is seen as failing a large chunk of the population.
And how would people actually use healthcare differently in that world?
Long term, you'd probably see less preventive care, less primary care being used regularly, people delaying things until it's an emergency. Chronic conditions get managed poorly until they become a crisis. It definitely points towards worsening population health stats. And you can see that two-tier system really harden. Good, comprehensive care for the insured. And then for the uninsured, maybe reliance on crowded public hospitals or expensive pay-as-you-go retail clinics.
What about ripple effects on the economy, on labor markets?
Yeah, you can see more job lock. People afraid to leave a job because they lose their health insurance. That can stifle entrepreneurship, reduce dynamism in the labor market. Employers might feel more pressure again to offer some kind of benefit to attract workers since options outside work are shrinking. And that hidden tax we talked about, uncompensated care costs getting shifted onto private premiums, that puts a drag on wage growth for everybody with insurance.
And the provider system itself, how does it reshape long term?
Consolidation seems almost certain to speed up. Big hospital systems absorbing smaller, weaker ones, especially in rural areas. We might see more vertical integration to insurers buying clinics and doctor groups. Value-based care. The pressure to make that work will be immense as providers look for stable revenue that isn't just fee-for-service. And maybe we see a bigger, more formal cash-pay sector emerge. More providers offering clear upfront prices for people paying themselves.
It's fascinating, though, to think that these OBBA policies might not last forever. You mentioned historical reversals. What's the chance the pendulum swings back after, say, 2030?
That's a critical point for any health plan strategist. History does show that major entitlement cuts can be politically volatile and sometimes get reversed or modified later. Future elections, new administrations, maybe court challenges, they could definitely change the trajectory. By the 2030s, we could easily be in another round of health reform, perhaps trying to patch the holes this bill creates. So agility isn't just about the next few years. It's about understanding that the policy landscape can and probably will shift again.
Okay, so given this really profound market shift, let's talk strategy. What should forward-thinking health plan companies be doing now? What's the playbook to thrive, to add value, to fill those gaps?
Right, playbook time. First big thing, design truly affordable alternatives. For the millions priced out of comprehensive plans, think low-cost subscription-based plans, maybe offering essentials, unlimited primary care access, virtual urgent care, cheap generics. Pair that with a high-deductible, catastrophic insurance wrap for emergencies.
Like an insurance light model.
Exactly. Something more than nothing, less than a traditional gold plan. It's a space many incumbents haven't really cracked.
And the OBBA's HSA-friendly rules actually help with this, right?
They do, which is interesting. Plans should lean into that. Market those HSA-compatible bronze plans, maybe bundle them with a direct primary care membership. This lets people use pre-tax HSA dollars for routine care via DPC while having a safety net. It's a way to capture members who might otherwise go bare, a move many traditional players are frankly missing.
Okay, what about serving groups, small businesses, gig workers?
Huge opportunity there. Offer things like level-funded or even self-insured options tailored for small employers. These can sometimes bypass certain costly ACA rules. Also, really push association health plans, AHPs. Aggregate lots of small businesses or independent contractors together. Get better negotiating power. Carve out share from insurers focused on big corporate accounts.
And DPC and virtual care, you mentioned them earlier. How central should they be?
Absolutely core. Non-negotiable for forward-thinking plans. Forge deep partnerships with DPC networks, telehealth providers, convenient care clinics. Make it easy and cheap to get basic care, even with a high deductible. Maybe integrate a DPC membership fee, $51 a month, right into the plan.
So no barrier to seeing a doc for basic stuff.
Right. I make telemedicine robust. 204/7 virtual urgent care, mental health counseling. This attracts cost-sensitive buyers and helps control downstream costs. It's something the big, sometimes clunky incumbents often don't execute well on.
Okay, what about that Medicaid gap? Millions falling between systems. Any specific products for them?
Yeah, this needs targeted solutions. Maybe develop low-income health sharing plans or cooperatives. Work with states or nonprofits on bridge programs for those losing Medicaid. You could even offer services around compliance, like tools to help people track their work hours for Medicaid verification. That's an administrative service that keeps you connected to potential future customers, too.
And with more people facing high deductibles or paying cash, HSAs are key, right? Both for the consumer and the plan.
Totally. Optimize around HSAs. Make sure plans are HSA qualified. But more than that, educate people. Help members understand how to use HSAs effectively for budgeting. Maybe offer tools, resources, even shared savings if they choose lower-cost providers. Plans need to become navigators, educators for people dealing with these new, often confusing coverage landscapes. Help them stretch their healthcare dollars.
Provider partnerships seem crucial, too. For cost control, new models.
It's essential. Form tight alliances, maybe joint ventures, with provider groups. Build high-value, narrow networks where providers agree to better rates, or maybe even take on risk through capitation. Really lean into value-based payments that reward keeping people healthy, not just doing more procedures. Health plans can actually become a bridge here. Give providers predictable payments for managing a population, including the uninsured or underinsured, and give patients coordinated, affordable care pathways.
And you mentioned rural areas getting hit hard. Is that a specific market to target?
I think so, strategically. Focus on rural and underserved areas. Trying to lead the way on rural health transformation, maybe leveraging some of that $50 billion federal fund. Partner directly with those struggling rural hospitals and clinics. Develop tailored insurance products or service packages that help them stay solvent while serving the community.
Could involve administering state subsidized plans, maybe?
Potentially, yes. And push telemedicine aggressively in those areas. It's key to bridging the access gaps that are only going to get wider.
Okay, so lots of specific plays. What's the single most important mindset or capability that ties this all together for health plans?
Agility, just pure, relentless agility. Be ready for policy whiplash. Build flexible modular products you can adapt quickly if subsidies come back or if Medicaid rules change again. Stay nimble. Cultivate relationships across the board brokers, community groups, state policymakers, both sides of the aisle, and invest in modern, scalable tech for enrollment, for admin, so you can actually pivot fast when the market shifts, which it will. Being smaller or more focused than the BUKAs can be a real advantage here. You can move faster.
So, the big, beautiful bill. It really is a watershed moment, isn't it? Reversing a decade of expansion, creating huge challenges. But as you're laying out, for health plans willing to think differently, to act decisively, maybe this disruption is also a massive opportunity.
Precisely. It's both challenge and opportunity. By creating these innovative, cost-conscious options, focusing on prevention, filling the gaps, companies can do by doing good, essentially, build a really loyal customer base. While the legacy players might be slow to adapt, these nimble, innovative companies, they can build a whole new ecosystem of solutions right under their noses. By the time the big guys fully realize what's happened, the innovators could have grabbed significant share by demonstrating real value to consumers left behind.
The whole healthcare market really does feel poised to shift beneath our feet. So for you listening, what stands out to you about how these changes might unfold? And maybe more importantly, what innovative steps will you consider to not just navigate this, but actually empower people with new choices in this evolving landscape?